Onc Live Insights is a video editorial program produced by Onc Live.
Historically, the way we've treated CLL was typically with serial rounds of chemotherapy or chemoimmunotherapy. Patients would generally be observed initially after diagnosis until they met criteria for treatment, which typically includes symptoms, worsening cytopenias, or increasing lymphadenopathy. They'd then be treated typically with a 6-month course of chemoimmunotherapy, go into remission, go back on watch and wait for however long their remission lasted, and then at time of relapse would often be retreated with chemoimmunotherapy as long as they had had an adequate remission, which has typically been defined as 2 to 3 years. With the advent of these novel BCR inhibitors in the relapse setting, interest in giving repeated rounds of chemoimmunotherapy has significantly diminished. This is in part because we know that remissions have always tended to get shorter with serial rounds of chemoimmunotherapy, and toxicity tends to become greater with particularly hematologic toxicity and likely an increasing risk of second malignancies like AML or MDS. So it has been fairly easy to move pretty quickly toward the novel agents that are not chemotherapy for the relapse setting for essentially any patient. The upfront setting is a bit more complicated in the sense that particularly for the younger fit patients, chemoimmunotherapy with FCR has resulted in often prolonged durable remissions. In fact, long-term follow-up data recently presented by the MD Anderson and German CLL study groups have shown that amongst particularly lower risk mutated IGH patients, there's approximately a 60 to 65% 10 to 12 year progression-free survival. And many of those patients are MRD negative, and there has been essentially a plateau on the survival curve, suggesting that some of these patients are actually cured by FCR, which was not necessarily expected from what we know about CLL historically. To my mind, this means that we need to be cautious before we throw FCR out in favor of chronic therapy with oral agents. Now, these agents are quite effective, but they don't result in complete remissions, and so they're likely not going to cure anyone as single agents. Furthermore, as single agents not resulting in complete remissions, we're rather likely to see evolution over time with emergence of adverse clones that may be resistant. I think, therefore, for these young fit patients, ways to move forward include combining the novel agents with chemoimmunotherapy, or perhaps combining novel agents with each other, but again with a goal of achieving MRD negativity and complete remissions that might rival what we have seen for some of these patients with FCR. For older patients, it's a little bit simpler perhaps because the chemoimmunotherapy is harder to deliver. Many of the patients don't tolerate it as well and need to stop early or develop cytopenias. So for these patients, it is perhaps easier to consider using single agents as upfront therapy, particularly if the timeline is not as long as well in terms of their expected survival independent of CLL. And in addition, the chemoimmunotherapy is generally not tolerated, and weaker forms of chemoimmunotherapy are not curative anyway. One important consideration for the oral therapies is their side effect profiles. Ibrutinib, for example, can cause cardiac toxicity, particularly atrial fibrillation, and is contraindicated together with anticoagulation. So these features can become important in an older patient population, many of whom may require anticoagulation or have pre-existing atrial fibrillation. Idelalisib, as it turns out, has an interesting cocktail of side effects that may be immune-mediated, although they're not fully understood. And these include a transaminitis that occurs generally in the second month of therapy. That typically resolves if you hold the drug, and you can usually restart at a same or lower dose. At later times, an immune-mediated colitis can develop, a drug-related pneumonitis in a couple %, and a rash. These side effects so far appear to be somewhat increased in an upfront patient population compared to a relapsed refractory patient population, suggesting that idelalisib may be better used in later line. Recent data has suggested that chemoimmunotherapy, in particular FCR chemoimmunotherapy, may have particular efficacy in mutated IGHV lower risk patients. These are long-term follow-up data from the MD Anderson, also confirmed by the German CLL study group, in which the mutated patients appear to have a long-term progression-free survival of 60 to 65%. These patients are probably many of them cured, as there are mostly MRD negative and late relapses have been uncommon amongst these patients. Therefore, the bar is high to discard FCR amongst this particular patient population. For the unmutated patients, only about 10 to 15% were still in remission out at that 10 to 12 year period. So it's not clear that that group was achieving substantial rates of cure with FCR, making it reasonable to potentially move more toward novel agent therapies. Interestingly, the B-cell receptor pathway inhibitors appear to have at least equivalent activity in IGHV unmutated patients as in mutated patients. This is not what we've typically seen with chemoimmunotherapy, where the higher risk unmutated patients do tend to have worse outcomes. However, with the BCR pathway inhibitors, we know that that particular pathway is more active amongst the IGHV unmutated patients, and it's been thought that perhaps this may be the reason why the outcomes seem to be similar for the mutated versus unmutated patients with these agents.